And the topic for today is how we are going to class and close the gap between the theory and practices. So actually there is a huge difference between the theory and the practice. Theory assumes an outcome, while practice allows us to test the theory and see whether it is accurate. There is always a gap occurs when the practitioner finds it difficult to integrate the knowledge what he has learned. Yes, if we talk about the theory and the practices, there is always a huge difference between the both. Theory assumes an outcome, whereas the practice allows us to test the theory and see whether it is accurate. The gap occurs when actually the practitioner finds it very difficult to integrate the knowledge what he has learned with the actual practice. Because as the standards of care continues to evolve continuously, because the standards, the guidelines is every time it keeps evolving. So there can be often disconnect between what is considered as best practice and the actual practice. What is best practice? It is derived from well-conducted research by taking few accounts for consideration, like preferences of patients, which means the expectation, what exactly the patient expects, and the experience of caregivers over period of time after the academics, during clinical practice, what exactly the experience of caregivers, that also has to be considered, and the ethical consideration, all put together we call as best practice. It is derived from well conducted research. If you see, as I mentioned earlier, theory assumes an outcome, whereas if you see the image here, as per the theory, this is how it will be. Outcome is already assumed. When we see practically during the practice, there is a question mark. It just sees the accurate, whether whatever we have learned, whatever we have read, there is always a comparison, and there is always a gap between the actual theory and the practice. What are all the obstacles we have when we really practice? Why there is a gap? Always there is a gap between the theory and the actual practice. According to a systemic review, the frequently identified obstacles are as follows: lack of awareness of the problem. Most of them, they themselves not aware there is a problem. They assume that this is how the practical difficulty will be. So the lack of awareness of the problem and the familiarity to the guidelines, that is also lagging behind. And the recommendation, though the recommendations are there, guidelines are there, there is a ignorance, and they are very comfortable. All are very comfortable with the whatever the practice, the inertia of previous practice. They are all, whether it is fruitful or not, whether the outcome is very much accurate or not, the way they have practiced all these days, they are comfortable in their own in their own way of practice. So these are all the obstacles. And how to bridge this gap between the theory and the practice? This is how we as a quality professional has a scope to work. There is a theory also, there is a practice also. There is a huge gap between these two. We have to bridge this gap. How? There are problem exist. We have to identify the problem exactly, and we have to measure it. This will increase the awareness of the issue, and we have to convince the non-believers that there is actually a problem exists. We have to identify, and we have to make them understand also. Secondly, an action plan must be defined. This includes the selection of action points by all the stakeholders, like policymakers, patients, and public health providers. Thirdly, yes, we have identified, measured, the problem, and action plan also we have defined. Next, what is next? Objectives. Objectives must be defined. There should be a realistic, clear, and limited. The objectives, whatever we are defining, it should be realistic in nature. Fourthly, if all of these steps, whatever we have done so far, we have to explain this to the stakeholders and come into it. It should be like a general agreement before we actually implement our plan. Why it is important? Because there will be a ignorance, there will be a resistance. So before only we have to take their consent. We have to come to a general agreement that this is how, whether they are okay or not. So we have to involve them also in the decision making process. So by doing all this, we can enhance the awareness and the behavior towards the problem, like what exactly is happening. We can, before implementation, this is very, very important. If not, what will happen? Again, there will be a gap, because we can plan, we can measure, we can put, everything we can explain, but ultimately everything has to be achieved, implemented by the frontline people. So for that, we have to involve them also in the decision making process. If we have to, if we want to be successful. So after all these points, the topic for the day, is theory practice gap. Yes, this topic is highly relevant for the current situation of healthcare quality, because it directly endangers the patient safety. It directly affects the patient safety. So now, as the nurses are often says, this is the right time for us to consider this gap and consider it as a scope for us to work on, and we have to put, we have to work together to bridge this gap and achieving the adherence, high adherence rates to the guidelines is really very difficult, as it requires lot of features to be taken for consideration, especially during implementation. The program should be well thought to the team, and we have to consider the features of the target group, social and organizational context should be considered. Then only the success of the program will be fruitful. If not, again there will be a gap. The guidelines are major and effective tools in the practice of delivering evidence-based practice to achieve effectiveness of better patient outcomes and safer care. How we have to, there are guidelines, and those guidelines we have to bring it into the practice. How? We have to invest. We have to invest in the knowledge. We have to give training for our people, to our team. So then only we can bridge this gap. And there should be a shift. There should be a modification in the behavior. There should be a positive culture in the organization. Instead of blaming culture, we have to build a positive culture. Like for identification of any problem, first of all, they should be open. Our people, the user end in the hospital, all healthcare workers should have that positive attitude to whatever incident happens. They have to bring it to the notice. So that kind of positive culture should be there, instead of having a blame culture. After the modification, we have to do the audit. What exactly happenings everywhere, because that is the source of our information. So when we have different kinds of sources, only we will be able to identify the exact problem. After identifying, only we will be able to measure it, and then we can analyze and put things into place. So all this I have told. Actually, I want to, I am not a actual quality person like you all. I am basically a operations person. So my perception on quality has changed a lot. Initially, I was thinking, what is quality? Quality is capturing the indicators. Quality is, we have to identify, there should be a, projects, process improvement projects based on the requirement, the project, process improvements and all done. This is what I was thinking. But after getting into exact, content, after seeing the contents, the delivery, the knowledge given by nurses, sir, my view of quality is changed a lot. If you ask me now, from the entry of the patient till the patient exits, everything is quality. But before, I was not thinking like that. Quality, yes, we have to do, because that is also a part of a practice. We have to produce a report. We have to, capture indicators in the month end, in monthly once we have to make a report and we have to present it. That is what it is happening currently also in day-to-day practice. But whereas, if you ask me now, everything, all patient experience is again equality, service excellence again equality. So there are, we have read so many things, we have the knowledge, but what we are doing with those knowledge, actually we have to implement it. But for implementation, we should have good support from the top management. So as a operation person, today I understood how much support, how much attention, how much insight we have to give for the quality person, whoever is working. We have to sit together. Quality is not just a meeting. Quality practice is not just an analysis of the interpretation of the report. That is the source of information. The entire process flow is based on quality practice. The patient, how the patient experience, the patient satisfaction, now everything is the quality practice. Today only I understood that. I mean, after joining receive only I understood that. And thanks once again, Tenarsu sir, for changing my entire view about quality practice. Same like me, I wish the hospital top management people, everybody should change their perception. Quality is not just accreditation work. It is not just paperwork. We're putting SOPs, making hospital manuals, policies, procedures, and it is all documentation. It is not so. Quality person should work to bring whatever is in the paper, that has to come in the culture of the organization. The entire culture of the organization is in our hand. So let us all work together to bridge this gap. And thank you once again for giving me this opportunity, sir.
Thanks, Dr. Fatima ma'am, for your short and sweet presentation. It was to the point, and the take-home point was when the leaders will start learning the quality, we can close the gap in the theory and practice automatically. And you have started doing that. You are leading by example. So we are happy that you want to learn about quality. So let's introduce to our next speaker, Mr. Vikram. He has done MBA and he is working in Health Point Hospital, Abu Dhabi.
Thank you, Dr. Tenasar, and thank you, Dr. Manjusha, give me opportunity to this presentation. So today our topic is closing the gap between theory and practice. When it comes to the healthcare, the theory and practice, it's totally, as per our belief, it's a totally different things. What we follow in a theory, it's very difficult to follow in our practice. Like Einstein said, in theory and practices are same. In practice, they are not. Actually, it's work in this way. Theory, if you see in a healthcare, in a different type, like as per JCA standard, we say like a pain assessment. We have to do the pain assessment. If you see in the literature. There is so many literature. If you search in the Google, you can find many opportunity, many, the categories that you can do the pain assessment. But when you come to the healthcare, there is a lot of things, totally depends on the healthcare, how they will do. And there is a turnaround time also, it's the same. Like turnaround time, if you see the radiology turnaround time or other turnaround time, when it comes to the turnaround time also, it's like in a healthcare, in JCI or NABS standard, it mentioned like pain assessment we have to do. If you search in a Google or anywhere in a for a literature or something, how many times you have to do the pain assessment per a shift, or how many times you have to do the pain assessment per per day for the patient, it will give you a different mean. There is a lot of literature you can find in Google, lot of literature. If you see, the American is different, European is different, but what is the right thing we have to select for our healthcare, that is completely different. So same like turnaround time, the radiology turnaround time, when we search for our improvement projects, we can see many turnaround time for a radiology things. Like we can see 24 hours, 48 hours, or 72 hours, and all these things. But when it comes to the real practice, we have to select the right things. That means, as per our definition, the quality, it says like doing the right things and right way in right time. But what is right for our healthcare, that we have to select. So we always, we always just select the practice and we just try to adopt in our hospital. It is not at all possible. It is not at all possible. When you adopt something from just you download, from the internet or the best practice, what is right for your hospital, that is completely different. You have to assess the following things. So here you can see, one, you should understand the scope of healthcare. How that means your healthcare. How it's a completely different practice. What you are doing in UAE or what you are doing in Middle East, it's a different than what you are doing in India. The healthcare is completely different. So, and cultural factors like cultural and religious factor, there is a culture, then you have to assess that one also, culture and religious factor. And the financial factor also you have to assess. Understand the concept. So why we are implementing the factors, why we are implementing this standard. For example, you want to implement the TKR pathway. You cannot implement the pathway, just download from the clearinghouse or IHI or something like that. You cannot implement it. We have to assess the culture. You have to assess. A few days before, for example, I was in the meeting, in a patient satisfaction meeting, and they are comparing our hospital patient satisfaction data with European standard, European patient satisfaction, one of the hospital. How we can compare our hospital data with something else in the Europe? Because patient expectation is something different. Patient, the care is something, different. So we cannot compare. When you are comparing also, when you are implementing the theory, what we have, because when it says theory, you just look at West, what America is doing, what Europe is doing. This is the fact. This is the fact. So we just adopt, we will take from them and we start to implement these things. But really, it is fit to our healthcare. Really, it fit to our culture. Really, it fit to our patients. So this is the main important we have to assess. So that's why the following things we have to assess very carefully in this matter. So implementation of maybe the clinical pathways or the comparing the data, what we have. Yes, we can come back. Today, we had a discussion when I'm just preparing this presentation. I had a conversation with my infection control expert. So I just asked him, how you compare your data, your infection control, for example, surgical site infection with NSHN, because NSHN, The 90% of hospital is Western, and their antibiotic and the resistance of antibiotic is different than ours. So culture is different. The procedure timing is different, and the time for surgery is different. The completely different, and we are just following them, we are comparing them. And he answered me, we are just following the standard that they are following. That, yes, as you said, there is a lot of factors, other things that we cannot copy that, because our standard is completely different. When theory comes, we cannot follow directly to in comes to CPHQ also same. I have 14 years experience in healthcare. When it comes to writing the exam CPHQ, I attend many mock tests, but I never get more than 90 marks out of 140. Never, ever. I attend many mock tests and never ever get more than 90 marks, because what we do is different than what is the practices, because the theory is completely different. So how we reduce the gap between the theory and practices, that's the only one. Dr. Tenarasa said, sir said one thing: implement it. So that's what I'm trying to do it, and I'm telling my staff also do the same thing. Like, what you learn, try to implement in your workplace. That's the best. What we hear, we hear a lot of, if you go to YouTube, if you go to Google, you find a lot of video about the practices. You will confused about this. But really you want to implement, when it comes to practice, which one is better for you? That is the main thing that you have to identify. Which is better for your hospital? Which is better for your organization? Which is better for your country, where you work, whichever, it is India or UAE or Middle East, wherever. That factor is important. So as I mentioned in my presentation here, there is a few factors are there. So this is very important. What is patient is expecting? So try to implement what we learn. If you implement it in your factor, like we learn about, from few days we are learning about data management. So when you do the data management, we learn so many graphs, so many stylish to present the data, how we can do it, and all this thing. If you just listen and you just write in the note, you will forget it unless you implement it, you work on it, you really do it. That's it. I done Six Sigma. My example I will give you. I done Six Sigma, Lean, everything like 6-7 years before, but I don't know anything about that now, because we never used in our hospital, or we didn't implement it. There is no opportunity to implement. So that's the best thing, that what we learn, what is the best for our hospital, or what we learn, just try to implement those things in our organization, or practice it, or do it in if you get opportunity. I don't know how many people will get opportunity to implement it in your organization, or how you can do it. That's what we are doing now. So there's a lot of factors like implementation, like few days before we implement like TKR, total knee replacement pathway from clearinghouse. Clearinghouse is one of the best evidence-based clinical pathway. They are from states. But when you implement it, you feel a lot of challenges, because when, for example, I'm from UAE, we have multicultural nurse. And it depends on staff competency. That's the one of the factor I mentioned here. When you implement something, it's all about competency of the staff, how competent they are to implement that things here. They're competent to do that. That means I mentioned here caregiver competencies. Caregiver means our staff competencies, whether we can implement that, they are competent to do it or not. That's why DOH means Abu Dhabi Health Authority. They said like 10 years before, whoever come with a nursing degree, they accept it. They will give you a license. Now, no, they should have proper, 4-year nursing degree to get the RN license. That's how they respect the competency of the nurses. And there is the exam and all these things. This is one of the factors. So again, the financial factors also available. So how we can get the financial things, how much support, how much budget we will get from the, from the management, all this thing to implement the certain things in our hospitals. So these are the factors are there. So the best things I will just tell my friends that the best thing is try to what you learn from the CPHQ or what you learn from this thing, just try to implement. But before implement, you have to assess your hospital. That's the right thing to implement. We have dental accreditation in our hospital, Australian accreditation. In Australian accreditation, that they say you have to assess who patient come for dental consultation. You have to assess their psychological assessment, sexual assessment. In this region, it's very difficult to assess all these things. See, there is a gap. So we cannot implement. There is certain way to make this clear. If you see the clinical outcome tool, we say, for example, total knee replacement, we use Oxford knee score for a clinical outcome to see the clinical outcome, quality of life, patient's quality of life. We will do that before surgery and after surgery. So in that, there is few questions regarding their sexual life, all this thing. In this culture, for example, in the Middle East, it's difficult to ask how we overcome that. So without that question, the tool, we cannot complete it, and you will not get the final score. See, challenges again. So same thing. So we have many challenges as per the factors. We cannot follow directly to, what I can say. Theory means you just look at West. So this is as per my experience. We cannot just look at West. We can take a reference from them. We can take a tips from them, and we can create our own things as per our organization, as per our culture, as per our, setting. We cannot just follow what they follows and all these things. So the following assessment is required for this. Thank you.
Let me introduce you to the third speaker, Dr. Binoy, who has done his BMS and then MHA, and he's working as manager quality control in Lakshmi Hospital.
So they have already given very brief on very detailed presentations on the gap of what exactly the theory and what we practice and all. So here we will go in for an example. So before that, just a quick definition of quality. This is from ARHQ. So that is the Agency for Healthcare Research and Quality. That is a US agency. So it says the degree to which the healthcare services for individuals and the population increases the likelihood of the desired outcome and are consistent with the current professional knowledges. So here we are directly going into one example of a hand hygiene. So already we have discussed much on what exactly is the difference between the theory and practice, where are the gaps, how to close the gaps and everything. So here we will go in for a practical session. So now hand hygiene is something that is very basic, and every hospital does a hand hygiene compliance rating, which is for the JCI accreditation, NABH, whatever agency it may be. So hand hygiene is one of the prominent one. So like if you are to reduce an AHA, when HAs, the hand hygiene compliance is much more important. So here we go in for a practice one. So where the methodologies matters. So what is a goal? So goal is to have an 100% compliance in hand hygiene, thereby reducing the hospital acquired infection. So the theory is we track the compliance rate in our institutions. So how do we track the compliance? So a very common practice in hand washing compliance is we ask our staff to ask us to it may be the ICNs or the quality persons who go around, and they ask the staff to perform a hand hygiene, and they will see whether they are following all the 6 steps, 5 steps, whichever they are following, and to see whether they are doing correctly. And if the staff performance correctly, then they will feel okay, fine, the staff know the hand hygiene and they're doing it. But where is the gap? So gap is actually for hand hygiene. If you look in for the guidelines from WH and all, they always recommend hand hygiene to be an observation tool. Now, what do you mean by observation tool? Observation tool means you don't ask your staff to demonstrate a hand hygiene. You observe your staff. Just go into a unit, your ICU, your casualty, your lab, your OT, wherever it may be. Just go and just observe around. There are a lot of opportunities that goes around. So what exactly is opportunity? So opportunity is one of the 5 movements of hand hygiene. So before touching a patient, after touching a patient, before doing a sterile procedure. So all these are opportunities. So just observe in your area. You can see a lot of opportunities going around, and observe how the staff is behaving or is reacting to each of the opportunities. Whether the staff is actually doing a hand hygiene. Hand hygiene means hand washing and hand rub. The use of hand rub and also hand washing. So are the staff doing it or not? So rather, if you ask a staff to do a hand washing, they will definitely do. I mean, especially in many hospitals where they have an accreditation, every staff will know how to wash the hands. But are they actually doing that in the practice? Now, as in the previous presentation, they already told about what the theory and the practice is. So theory says like how is hand washing done, but in the practice, are they actually practicing the hand washing in the opportunities that is given, or in the opportunities that is there, whether they are actually following the hand hygiene steps? Now that is important. So rather than going around and asking your staff to do hand washing, you should always observe. Just go to your unit, just observe around, because observation is a very important tool for a quality person, because you observe around and you see many things. Because I personally have a very good experience on that. So so on hand washing especially, the observation is the best tool to see that how best is your hand washing compliance. Just let me know if I'm going too fast. So the next practice is on the hand hygiene sample size. Now, this is a very important one. So on hand hygiene, the goal is to get a data about the population, where the auditing of the entire population is practically not possible. So everybody knows we have the sampling size. So sampling size differ from 5, 10, 20, 100, 200. It actually is on the wish of the department. Maybe in 1 month they will do 100 audits, or in another month they will do 200, or whenever they get time they do the audit. So the number of samples or that is not been always predefined, or in some cases there is always a predefined numbers that every month we'll be looking into specific numbers. Like we will set that 200 is the number of hand hygiene compliance that we'll be noting in a region, or in a particular area we'll be looking into a 200, 100, whatever number it may be. So what exactly is a gap? So gap is when you choose the sample size. If it goes wrong, then you are not going to get an adequate data, or the data that you're getting might not reflect the complete population, or you might not get the complete result from the sample. So how do you close gap, especially on a hand hygiene. So definitely we can use a statistical formula to find the minimum samples required from a set population. Now, there's actually a formula that is used where the small n is a sample size, and capital N is a population size, and CF is a correction factor. So this is a statistical formula which we can use to get the number of samples. Now, here one question that might arise is, how do you find the population size? Because we don't have a population here. Hmm. If you want to look for our patient satisfaction, there is a population, the number of patients who is coming to OPD, the number of patients who are coming to IPD, all those are the part of the population. But how do you get a population for our hand hygiene? Now, a good thing that there is one thing that I am following. So please correct me, or if just let me know if you have some better tools. So what I follow is the population will be the total number of our clinical staff, the doctors, paramedic, nurses, all those people, and how many actual opportunities that they can get in a day. I start with a very minimum number that every day they will get at least a 5 hand hygiene opportunities. So into 30 will be your population. So like that you can have a sample to start with. And the last one, the larger the sample, the better. So once you are, if you see that your complaints rate is increasing and it's almost close to 100, there's 5 for every person can be increased to 7, 8 or 10. So you get more number of samples, and you can evaluate whether the actual the complaints that you're getting before and after is almost the same, or whether we are lacking on the data. Because as of now there is no specific or agreeable sample size on hand hygiene, because if you refer WHO, CDC, anything, they don't come into a recognized numbers that this is the number of hand hygiene that is required, because department to department differs. In OPD it might be less, but in ICUs, OTs, in labs areas, lab collection areas, the number of opportunities will be very high. So you can calculate the population or the sample from the department sites, or from each the departments you can make the sample size, or you can, if you don't have any sample size as such, then you can start with this, and then you can gradually go into sample size for each department. So the next one is on the random sampling bias. Now, we told, like, we actually discussed on the number of samples. Now, let's say that we have set one particular number of samples that we are going to do. Now, what exactly is a random sampling? So, random sampling is one that we do from the population to see that that we get a unbiased result. So we usually choose the nth sample, or the first of the nth, or the last of the nth. So all these things we do. But in theory, it says that the to get the exact number of hand hygiene complaints, we need to observe all the people, like the doctors, the nurses, the paramedical people, the housekeeping staff, the clerical staff, even the areas, which all areas we need to see for hand hygiene, the wards, ICU, the collection areas, the HDUs, all these areas are important to get a sample. Now, what is sampling bias? So it has three basically. There is an observation bias, there is an observer bias, and there is a selection bias. So what is observer bias? So observer bias is like if the person who is actually auditing the hand hygiene, if he or she does not have a complete knowledge on how to assess on what exactly she or he should look into for hand hygiene, then there is always a bias on how he or she is looking at the data, or the data tool, or the audit tool that they are going with. So one thing is the standardization of a audit tool. So one thing that we can recommend is the WHO hand hygiene tool. So it's a very beautiful audit tool. So one is the standardization of an audit tool for all the observers. So when I am saying all the observers, you can have multiple people working in or the department, the ICNs, the infection control team, the quality team. So everybody will be using a single or a agreed one audit tool, and selection bias will be the so here what happens is you pick a particular department on a particular day. Let's say that for example, every Monday I'll be going into the ICUs. So every Monday or I mean the subsequent days, Tuesday and Wednesday, I'll be going to ICUs first. So this becomes a pattern. So when this becomes a pattern, the staff knows that Monday, Tuesday, and Wednesday morning time, somebody will from the quality department or the infection control people will be coming there to audit the hand hygiene. So that becomes a selection bias. So what we can do is not to make a pattern and totally random. Pick a department at random and go in for a observation. And here one thing I have not mentioned is an observation bias. So what is observation bias? So basically, observation bias means when you go into a department, so you are a known person, the quality people, the ICNs, the infectional team, they are known with the hospital staff. So once you go in, they always become conscious. Okay, somebody from the quality department is there, or somebody from the infection control team is there, or somebody from the ICN is there. So he or she has come here to observe something. So this becomes an observation bias actually. So how we can actually cover this is a bit difficult actually, but still it can be done with a lot of practice and experience. Actually, even you can go into an area and do some other work, or can ask the staff some other data and still observe the hand hygiene complaints. So this take experience, like, but still that is a doable thing. But one thing that we can clearly avoid is an observer's bias and a selection bias. So next one is on doing an RCA. So now this is a very common practice. So we do RCA for almost everything. So whatever is there, if there is any incident in the hospital, whatever small or high, we always go in for a RCA. So the purpose of RCA that we do is to know what exactly has the cause of particular incident or event that happened. So what exactly has happened to the grassroots level we are going. So we do all the fishbone analysis, and then FMEA, all that we do. Now it has become a practice with almost a good number of hospitals and with the quality team and with the infection control team to do RCA for each and everything. Each and every incident goes for a RCA and CAPA. And I don't actually fully blame the department, because my experience with an ABH is the auditors, when they come, they will always ask whether you have done the RCA and CAPA for event. So everybody, it becomes a practice that you go in and do the RCA for each and every incidents or events. But that is not required actually. That is actually not required, because that actually kills much of a time, and effort is required. So do RCA for those things which is actually required. So when come to let's come back to hand hygiene thing. So when we come to hand hygiene, so how we can close the gap? The closing the gap will be on collecting more data. See, when you're going into hand hygiene, it is not only just whether they have done the hand hygiene, yes or no. That is not. That is only a partial data. So here we have to see the compliance on the 5 movements of hand hygiene. At what time they had to do the hand hygiene and what time they missed. Is it always before the touching the patient they are missing the hand hygiene, or is it after the touching the patient are they missing the hand hygiene? So where exactly is the missing? So the compliance on 5 movements of hand washing and data of the hand hygiene actions. So what was to be performed and what should, or what exactly they have performed. So what exactly is the gap, and also the categories. I mean, our different healthcare workers, the doctors, nurses, paramedical team, all our housekeeping, all those, and the different areas also. So if we get data from each, or the more the data, the better, what we have seen before. So if we get all this data, actually we don't need to do an RCA, because this data itself will show us like where exactly is lacking. But here the important part is like we need to have a data, a compiled data on all these things. It is not just that whether the staff is doing yes or no. No, where exactly are they going wrong? Hmm? So those things if you're doing, we might not need to do an RCA. I mean, this might not be the case for all the other quality indicators, but still, if you really want to do an RCA, you can always go in for a proper visualization tool like control chart or something, which can show you a trend. I mean, is there any special cause on something? So if you do the RCA for those cases, those special cases, that actually will give you a better result than doing RCA. Like RCA becomes a regular thing for each and every event we go in for RCA. No, for the exact events, the special causes that is there, which is causing the deviation. If we do RCA for those events, then actually we can have a difference, or you can actually see a visible change or the result from the RCA. The next, so the next practice 5 is on the last one, the display tools, the graph, which I think everybody is aware of, because everyone presents their data to top management. We have the monthly data, yearly data, quarterly data. We just displayed. I mean, how many is the hand hygiene complaints of our staff? Like for nurses, how much it is? For doctors, how much it is? All those things we display. But are we displaying it in the right way? Because I think few last time we had a presentation from Dr. Anshu ma'am, which actually gave a nice presentation on the difference between bar chart, a line chart, and a control chart. So here also it is important when, especially when you are coming into a hand hygiene complaint, there's a time series data. So we always can go in for a control chart. So control chart, we can always see whether our process is stable. Is there any common causes? Is there special causes? And if special causes are there, those we can go in for a RCS. So, so bridging the gap, actually, you have already seen two good presentations. So the basic thing would be to, because I would actually continue from where Dr. Vikram has told, because it is very important to understand the culture of your hospital, your institution, because it is not that I am telling something, or CDC is saying something, or WHO is saying something. No, you need to understand the what exactly is required, what is the knowledge, what is the theory that is required, and apply it in your hospital in such a way that it is applicable, or it will be helpful for your hospital, rather than just copy pasting it from the CDC and the WHOs. You should actually see what exactly the practice in our hospital. I mean, how much is the opportunities that is there in our hospitals for hand hygiene. So any quality indicators or the quality, you should always see how that can be applied in our hospital. Then only that can be those indicators can be, or that quality theory can be properly applied. Otherwise, there's always a gap between the theory and the practice. This is something just an extra, and this is a WHO hand hygiene observation tool. You can always search in Google. It is available, because it's this is a very good tool actually, which says what are the indications. So the indications are opportunities, then the hand hygiene actions, whether that should be a hand rub, whether that is a hand washing, whether they missed, whether they had gloves on, all. So this is a good tool that we can use. This actually is an ATP hand hygiene or a hygiene monitoring system. This actually I missed it on the methods. When the methods I told about the observation tool. So there are other tools also to know about hand hygiene. I'm speaking especially on hand hygiene. So there are other tools where they look into how much is the consumption of our hand hygiene liquids, or the hand rub, or the hand washing towels, how much has been consumed. That also has been seen as a measure of complaints. But those actually does not add too much into, because some staff might use more liquids, some might not use more liquids. So that is not always a correct method. Then there is a surveillance method, where you can keep a camera on your hand washing station and observe like somebody can sit or record and observe how many hand washing and has been done, or we can use something as of a ATP machines, which actually give you a result once a staff says that I've already wash my hands, and you can just see means swap a sample and see how many organisms are there. These all are just techniques, but I would my experience is the observation tool is the best way to observe a hand hygiene. So, any questions? I hope I did not go too fast. Any questions?
Thank you, Dr. Binoy. It was a really nice presentation, and yes, in a little time slot, you have covered many things with examples. So it was a good presentation. And any questions from the professionals, from all the three speakers?
I would just like to add, if sir permits, a very nice presentation, Binoy sir. There's a very nice technique to nowadays for this hand hygiene, which is also very economical. It's a glow derm gel. I can show you the photo in the next class when we have. So it's a very nice kind of a gel, like a hand rub. And the post hand hygiene, you can just place that, and if you do it with a UV light, you'll be able to see what are the areas where we missed the hand hygiene. So, sir, in next class, if you permit, I'll be able to show that. So we are
Yes,
actually
ma'am.
practicing. Yeah, we are
I have seen
practicing.
that actually. I've seen that actually, and that is actually a very good tool actually.
Yeah,
Thank you
and
for
it's
adding that.
very economical, and it's called Glow Dem Gel. So if you apply that gel and put it in dark, and then just put a torch, you'll be able to see the crevices in your hand where it has not been done. A hand hygiene, hand rub could not be done. So you will be able to
And
see
whether
that.
they have actually done the hand washing in the right way or not.
Or even on also on the touch surfaces, like on your beds or cots. Once the housekeeping staff cleans it, and if you put it that gel, and then if you see under that UV light, I mean normal torch light in the dark, so you will be able to see whether they have cleaned it properly or not. So it's a very good kind of surveillance tool to that, add to that. It was just an addition from the side that I wanted to add, that this practice is also, I feel it's nice for the surveillance and observation, as Mr. Binoy sir has very well explained. Thank you.
Where they have been using this, no, the UV light, where the staff has been asked to do the hand washing, and they have been asked to put the form into that actually. So when they have been put in, when the UV light has been set, they can see where are the areas where the hand washing is getting completed, where the areas the hand washing is inadequate, where the areas where the viruses or the bacteria is there actually. So they are showing that they do it in a once in a month's time. The one company is coming and they do it actually.
I'm
Please
Dr.
go ahead.
Jaswant Karneja. I'm speaking from USA. In fact, for operation of any eye surgery, we have an operation theater, and before any surgery, one has to scrub the hands. And we have a protocol in which we are advised to wash our hands for minimum 8 minutes. What is done is, at the spot where we wash our hands, there's a tap, and as you switch on the tap, there's an alarm there. The watch starts. You keep washing your hands, and after 8 minutes, the alarm starts. It indicates that your time is over. But if anybody who doesn't wash properly or puts the tap off before 8 minutes, the alarm rings in a different tone, which states that he has not washed his hands properly. So it's a simple monitoring how to scrub your hands. Within 8 minutes, you have to scrub your hands. And if you scrub it before, if you close the tap before, the alarm tells you that it is not properly done.
Special thanks to Dr. Pramita and Vikram sir, as well as Dr. Binay sir. Yes, so what I learned from this session, uh, there is significant gap in our practice as well as theory, but What are things we need to do to close this gap? As a quality professional, as a patient safety officer, even as a physician, what are things we need to focus to close this gap? Because always gap analysis is more important for our patient satisfaction, for customer satisfaction. Which one is more important? Gap analysis, correct? So how we are going to close the gap between practice and theory? As per research, so what is the conclusion from our research literature? Theory we can create. Theory is more appropriate for each and every organization. Theory we can use for each and every organization, but practice we should create from our organization. For practice, what we need to do? We should learn from our data. If there is practice, if you are going to learn from your data, we can do many research. Research is the practice. The difference between practice and theory. Only from practice we can able to do many research. Is it possible to know the evidence-based practice without research? Even for clinical practice, evidence-based approach is more important, correct? So I think this is very clear from this session. We should learn from our data, and always we should collaborate. Collaboration is more important. Collaboration between physicians, nurses, and quality people. Teamwork. If there is no collaboration between quality and physicians and nurses, how can we close the gap? How can we do research in quality and patient safety? So research is the only option for this gap. If you do more research, if you convert your performance improvement project as research, definitely we can able to close the gap between theory and practice. And one more recommendation from my side, as a statistician, if you collect more quantitative data instead of qualitative, no more quality, even if you compare total quality management and CQI, now we cannot use TQM. So similarly, for quality practice and for patient safety science, we need to collect more quantitative data and try to use more appropriate statistics. I'm sure from this practice we can create many practices, many different practices for our organization. And even what I learned exactly from Mr. Vikram presentation, developing our own threshold, always we need to create our own threshold, even for hand hygiene complaints. So what is the internal threshold for your organization? How can we compare with the JCS standard? So these are all we need to focus, and this is the main root cause for this problem. So how we are going to close the gap between theory and practice? Don't focus on policy and procedure. This is not the right time to do only policy and procedure for quality. No. Try to learn from your data and convert into research. Because if you do research, sometimes we can provide some solution to the whole community. And we can develop our own standard. The internal threshold for hand washing complaints, internal threshold for hospital-acquired infection. This is the first thing we need to do before going to JCI and NABH, correct? So this is very clear from these presentations. Thank you, Vikram sir and Dr. Binay sir. Thanks for your sharing. This is more important for quality practice. We should share. If you know something about quality and patient safety, always we need to share to others. So this is to create data-driven culture, positive culture, learning culture. I'm sure that definitely from this we can able to close the gap between the theory and the practice. Thank you, Dr. Manjusha ma'am.
Thank you, sir.
Thank you so much, sir. Thanks, everyone.